we have to move to the third speaker, Dr. Hussein AlAmri, who is a senior interventionist in the Prince Sultan Cardiac Center. Dr. Hussein has a huge experience in left main stenting since long time, and he will tell us today about tips and tricks in left main stenting. I hope you finish in time, Dr. Hussein.
Assalamu alaikum. Thank you. I hope so. Thank you, Abdullah, and thanks for the organizing committee. I'm going to skip whatever was mentioned by my colleagues. The most important step in left main intervention or in any intervention is planning. If you don't plan, then most likely you are planning to fail. So the first question you need to ask yourself is when to treat. And if you depend on angiography alone, most likely you are not going to do the right decision because of the limitations of angiography and poor correlation between angiography and other assessments, either imaging or functional. And again, if you revascularize based on angiography alone, most likely you're going to do a wrong decision because cabbage is harmful and PCI also is harmful in patients with intermediate lesions. So the best approach is to use the three steps diagnostic approach, which includes coronary angiography. If the lesion is more than 70, then most likely it's severe. If less than 70, then you need to assess with functionally with FFR or IFR, whether it's causing ischemia or not, and with imaging to guide your management. And the reason is a lesion that you may not see on angiography may be significant on IVAS, like this case, and a lesion that can look significant on IVAS may be non-significant on imaging. And again, sometimes you see a lesion that's significant on both IVAS and angiography. However, the FFR will be low or the opposite, where it looks insignificant in both, but the FFR or IFR will be positive. And this is multifactorial because we know that there are different cutoff values for MLA, and it depends on the patient size, ethnicity, the way you image, whether you do it from the CERC alone, LAD alone, or both. And again, what's good for a huge guy or a large body surface area is not good for somebody with a small body surface area. So whenever you consider left main intervention and you consider IVAS, you have to assess other factors that could affect your decision, like an IVAS area less than 5 can be appropriate for a small body size, somebody who's elderly with sedentary life, while even 7.5 or less will not be appropriate for somebody else. In these cases, you have to go for other testing like functional testing. So to decide whether ischemia is significant or not, or to treat or not, then you depend on FFR and IFR. And to decide how to treat and how to optimize, then it's IVAS or OCT. And also for the result assessment, it's IVAS or OCT. So which technique to use? If you deal with mid-shaft and ostial left main, then IVAS is better for diagnosis and probably for also assessment. However, if you deal with distal left main and bifurcation, by all means, OCT gives you better image, better resolution. It can assess expansion, edge dissection, tissue prolapse, thrombosis, and even can assist you in deciding where's the wire, where did you cross distal, proximal, or mid of the stent. And you have to know that it is safe to defer your intervention based on IFR or FFR, and you don't need to worry about that. And always use imaging to guide your pre-PCI planning, PCI itself procedure, and post-PCI. So probably you will need 3 runs of imaging during this, during your intervention. So how to integrate all of them? You first assess the lesion, whether it is functionally significant or not with IVAS and FFR. And then if you decide to treat, then you go with IVAS-guided treatment. One of the lesions that probably sometimes we think it's easy to treat is ostial left main. However, probably it's one of the difficult lesions to treat because of difficulty in landing or nailing the ostium of the left main. In these cases, you have to prepare your lesion very well. You have to guide your intervention with IVUS to know the appropriate size and where's your landing zone at the aorta, and always try to find the best view to do that. Otherwise, you will have what's so-called geographical miss, which can be due to you did not do your procedure very well and you did not land your stent, or it could be due to anatomy. Sometimes the angle is very oblique or very deep, and then you cannot really deploy your stent, and you have to accept this result. And this is important because in these patients, if there is a geographical miss, the outcome is worse than in patients with good stent landing zone. Other challenges are damping pressure, which we all know how to deal with it, and also with rocking stent. And in these cases, probably you can use a second guide wire. You can manipulate your guide catheter. You push it down until you fix your catheter and stop it from moving. You can use a floating wire technique, or what they call bumper wire technique. And sometimes there's an ostial bro, which is an excellent device that you can use to deploy your stent. However, it did not gain much popularity, I think, because of the price. One technique that we all use is a floating wire technique that can prevent guiding catheter from engaging deep into the coronary. At the same time, it will mark the aorto-ostial landing zone for you, and you can deploy your stent safely. This is an example of ostial bro used in the coronary. The marker can serve you to land your proximal edge of the stent, and then you can deploy it. In funnel shape left main, always try to oppose it to the wall, and sometimes you can use the flash ostial balloon, and always be aware of elastic recoil, which can occur with stenting, and you treat it with another stent, and the reason is high elastic fibers in these patients. What about left main bifurcation? When to treat is again the same. You decide whether to treat or not based on IFR, and you manage your BCI according to the IVUS measurements, and you optimize it also according to IVUS or OCT. Always remember that what's good for one patient is not good for the other. The first step is that you do angio, because in around 50% of the cases, it will, you do IVUS. In 50% of the cases, it will change your strategy. What looks like Medina 1, Medina 010 is different. And in this image, it looks 110 rather because of IVUS. So IVUS always can change your management strategy. The first question to ask yourself, is it true or non-true? If non-true, then it's provisional stenting. The second, if it's true, then you go for the whether it's complex or not. If it's simple, which is 101, then you treat it with provisional stenting. If it's complex, then you look at the side branch ostium, you look at the side branch lesion length and other criteria that defines high-risk lesion, and according to that, you plan your strategy. For simple, you go for provisional stenting, you optimize, you do IVUS, you assess your side branch, and you treat accordingly. For true complex lesions, which are 111 and 011, then you better decide from the beginning whether you want to do a two-stent strategy or one-stent strategy. If the angle is favorable, then you go for DK crush or T. If not, then you go for DK crush or Kilot technique. Why we always stress on the angle? Because the more the angulation, when the angle is very oblique, the ostium becomes oval and becomes very long. It's very difficult to rewire. There is higher risk of carina shift when you put another stent. The ostium is also very long And if you use a T-stenting, you will miss either the proximal or the distal osseum. If you use tapped technique, then most likely you will result in a very long carina. That's why looking at the angle really decides what technique you will use and also reduce your procedural complications. With oblique or with narrow angles, then you have to be aware of vulnerable carina or spiky carina or eyebrow sign, which can lead to complications after stenting. You have to be familiar with your technique, how to do it. And remember that side branch pre-dilatation is not recommended. It may cause complications more than it will help you. And in multiple studies, it was shown that there's no benefit except in special cases. In provisional stenting, both is mandatory. It facilitates further procedures to your PCI, and how to perform it. You have to mark the distal edge of the carina, then you place your marker of the balloon just before it, you inflate, and then you optimize the proximal segment. If you go too proximal, then you will not cover the osseum. If you go too distal, then you will oversize or overstretch the distal vessel, and you will also displace the carina, and this results in worse outcome. Always assess your side branch, either with imaging or with IFR, because most of the time what you see is not what's really there. And in only 7% of patients who had significant lesions on angiography needed intervention. So currently, IFR guided or FFR guided intervention for the side branch is recommended. Final kissing, again, there's no benefit, there's no harm, and it's not recommended. In Nordic bifurcation, there was no harm. There was harm rather than benefit. Again, you have to plan your two-stent strategy from the beginning, and remember that in all studies, DK crush is the best technique. In Excel, final kissing is not beneficial, even with two-stent technique, while in all other studies, it's a must. Use IVAS to decide where's your landing zone, and always remember that your eye is not an IVAS. What you see and what looks good in angio is not what you see exactly. Again, IVAS can exactly show you, and OCT, where is the wire crossing? Is it proximal, distal, or not? And the IVAS optimization criteria, according to Excel now, has changed to larger areas, and currently, because of different patient sizes and eccentricity, you optimize to distal or proximal reference area rather than to. Give me the minute, please. You give to everyone.
1 minute, yes.
لا برنس سلطان له 2 minutes أو 3.
Oh, thank you. So again, you optimize according to the distal or proximal reference size rather than an absolute value, because sometimes you cannot achieve this absolute value. Why I can't move it? Again, remember that when you cross proximal or in provisional stenting, that most likely you will have more difficulty in the procedure. Both landing zone is very important. In this example, the patient had provisional stenting, and then both was done too distal. The circ area was normal initially, but after both it became it became less than 4, and he had BCI kissing balloon inflation. Kissing inflation does not mean that you have to stent the lesion. Again, the initial decision and planning is important. This is a calcified left main, and the operator decided to go for intervention without debulking or without assessment with IVAS. However, it was non-dilatable lesion, so he did an IVAS, and there was around 180 degree of calcium in the coronaries. Despite that, he decided to go for a larger balloon. And what he ended up is significant dissection, which complicated his procedure, and he had to extend his stent into the LAD. Dual antiplatelet at least for 12 months according to EBC. And hemodynamic support, you have to consider it in patients who are high risk. And if you decide to use, you have to use it upfront. Don't wait for complications. So make your procedure simple. Make it as provisional as much as you can. Avoid complications by avoiding complicating your procedure. End up always with imaging and optimize with imaging, which improves life and improves prognosis. Thank you.
Thank you very much, Dr. Hussein.